slides that are on the website, you'll see that I just added one slide. I cannot project it because I can't convince this computer that I'm not Janet Sparker, and so I can't get access to my course. So I don't know does anybody know how to do that? I don't know how to do it. Anyway, if you look on your own computers, you'll see that there's one slide added. I think it's the second slide. Okay, it's not relevant until we get to the discussion of cholesterol, but that's coming up, and I wanted to give you something that's a little bit clearer than the diagram that's in the book. Okay, so all right. So last time that we were together, we had finished talking about the valvular heart disease and cardiac murmurs, and so now it's time to take up diseases of the electrical system of the heart. And is Professor Sparker, is she doing EKG with you now, or are you doing cardiology, CMS?
We are doing cardiology, but we haven't done EKGs yet.
Okay, all right, so you haven't had EKG. Have you got any exposure to EKG yet in cardiology?
Very briefly.
Okay, so this will serve in the way of an introduction. You know, the book, their treatment of the topic is not great, but there's at some point in time you have to be exposed to EKG, so I guess this is as good a time as any. All right, so let's talk about arrhythmias. They make the point that arrhythmias can refer to either tachyarrhythmias or bradyarrhythmias, or you can have an average heart rate that is normal, but there is something abnormal about the rhythm, an irregular rhythm. We'll talk about some of those things. If you take a look at figure 113, they depict in very simplified fashion the electrical system of the heart, the conduction system of the heart. Okay. And this is also going to depict it here. So here you have the sinoatrial node. You'll see that the electrical impulse is going to begin here. As you remember from physiology, there's pacemakers all throughout the heart, right? The whole heart is basically full of pacemakers, but generally the one that beats the fastest is the one that captures the entire heart, and the sinoatrial node generally has the highest intrinsic rate, and so it is the cardiac pacemaker. So the electrical impulses are going to descend. They're going to reach the AV node, where most of the delay in AV conduction takes place, and then they're going to travel down the bundle of His, and then down the right bundle branch and the left bundle branch, and activate the two ventricles essentially simultaneously. Okay. Okay, you can see in terms of conduction velocity, this basically depicts why most of the delay takes place in the AV node. You see the conduction velocity is a fraction of what it is in the atria or even in the ventricles. Okay, so that's why the conduction delay takes place there. Okay, so let's look briefly at the components of the EKG. Okay, so this is basically what you have in your book, figure 114. The P wave, okay, corresponds to depolarization of the atria, electrical depolarization of the atria. Electrical depolarization is going to precede the mechanical atrial contraction. The QRS complex, or S complex, is going to represent ventricular depolarization, and then the T wave represents the ventricular repolarization. Okay, what they don't show you here, but what they do show you in figure 114 is that sometimes you can have a U wave, which is a wave that follows the T wave. It's a small wave that follows the T wave, which can be more prominent in certain states such as, for example, hypokalemia and the like. So this basically represents one cardiac cycle, and then the thing repeats itself all over again for as long as you live. Okay, so let's talk about their discussion of the arrhythmias. And again, there's different ways of classifying the arrhythmias, but one that's commonly used is to talk about tachyarrhythmias and bradyarrhythmias. As I said, you can also have abnormalities of the rhythm, even though the average rate is normal. So that's something else to keep in mind. Another classification system that's sometimes used for arrhythmias is based on the origin of the arrhythmia. So one can distinguish, for example, between supraventricular tachycardias or supraventricular arrhythmias that originate in the atria, and ventricular arrhythmias that obviously originate in the ventricle. You can also have junctional arrhythmias, obviously, that originate in the junction. So let's talk first about bradyarrhythmias and bradycardia. Okay, if you look at figure 115, you remember that the normal heart rate is between 60 and 100. So if you have a heart rate that is less than 60, and if that rhythm is originating in the sinus node, we say that is a sinus bradycardia. People can have sinus bradycardia for a number of reasons. People can have sinus bradycardia because they have intrinsic disease of the sinus node. People can have sinus bradycardia because they are taking an agent that lowers the heart rate by affecting the sinus node. People can have highly trained athletes, young people, marathoners, people who are in good aerobic condition. They often have a lower resting pulse rate than their peers. That's sinus bradycardia. Okay, and that reflects high parasympathetic tone, high intrinsic parasympathetic tone. So it doesn't necessarily, just because you have sinus bradycardia, it doesn't necessarily mean it's a bad thing. It can be a physiologic adaptation. If you look at figure 115, panel B, you'll see that sinus bradycardia is going to look like a normal sinus rhythm. Okay, we'll talk about normal sinus rhythm and somewhat. We'll talk with Professor Sparker about that. But they will look. They'll look the same, except that the frequency of the complex is going to be lower, so the heart rate will be less than 60. And you'll learn in EKG how you can look at that rhythm strip, look at that paper, and quickly calculate what the heart rate is. You'll also learn in EKG that there are things that you can look at on this pattern to identify that a rhythm actually is originating in the sinus node as opposed to somewhere else in the atria. Okay, you'll talk about that with Professor Sparker. At the bottom of page 6, the one thing I want to make clear, they list as causes of bradycardia, they list decreased SA node firing rate and conduction block. Okay, you see that in figure 116. But it's important to realize that the blocks that they're talking about are going to be here or here. If you get a bundle branch block, left bundle branch block or right bundle branch block, that's not associated with a bradycardia. Okay, that's usually associated with an abnormal appearing QRS complex. Okay, but it's not associated with sinus bradycardia. So the delays that they're talking about, the blocks that they're talking about, are either going to be here or here. You also remember probably from physiology that, remember we said that the heart is full of pacemakers, okay? And it's the fastest active pacemaker that's going to tend to capture the heart. So it's usually going to be the sinus node. If the sinus node is lost, then you'll get an atrial pacemaker that may take over, an ectopic atrial rhythm, an escape atrial rhythm. When if they're not capable of taking over, then you'll get a junctional escape. Okay? And then as a last resort, you can get a ventricular escape rhythm. And ventricular escape rhythms are particularly slow, on the order of 30. Junctional escape rhythms, about 45. So as you go further and further down the heart, in terms of the list of pacemakers, the escape rhythm becomes slower and slower. Okay. So if you look at figure 117 on page 17, they are depicting somebody that has a ventricular escape rhythm. Okay, so why might they have that? They might have that because, for example, there's complete heart block. Let's say there's complete blockage of the AV node, so no impulses originating in the sinus node are able to reach the ventricles. So unless a ventricular pacemaker takes over and captures the rest of the lower chambers, there's going to be asystole. So what happens is that you'll get a focus that's depicted in figure 117 as being in the left ventricular free wall, which is going to be, like I said, about probably 30 times a minute is what you'd expect with a ventricular escape beat. And the other thing that you notice about that ventricular escape beat is that it's bizarre looking. If you look at the QRS complex compared to the QRS complex that you see in figure 114, which is usually narrow, is narrow. You see it's less than 3 of those little boxes. Okay, whereas with an escape beat, with a ventricular escape beat, you'll see a widening of the QRS complex to more than 3 of those little boxes, and you'll have a bizarre pattern. And again, that reflects the fact that the heart muscle, the ventricles, are not being activated this way, which is the efficient and fast way to do it. They'll all be activated essentially simultaneously, but rather the electrical impulse has to make its way through the myocardium of the ventricles. It's kind of inefficient. It takes longer, and that's why you have a wider QRS. Everybody understand that? Okay. Let's talk about heart block. We're going to talk about the first, second, and third degree heart block, and we are talking now about AV block, atrioventricular block. So block from something that's blocking this from activating the ventricle. Okay. First degree AV block basically refers to only prolongation of the PR interval. Okay, so a normal PR interval is 0.12 to 0.20 milliseconds. If you look at page, let's see, you see the little boxes there on page 15, figure 114. A normal PR interval from the beginning of the P wave to the beginning of the Q wave a normal PR interval is 3 of those little boxes to 5 of those little boxes. Okay? If it's more than 5 of those little boxes, okay, then, and that's 0.0, each of those little boxes is 0.04 seconds. Okay? So 5 of them would be 0.2. Okay. So if it's longer than 0.5, so the PR interval is greater than 0.2, longer than 5 boxes, greater than 0.2, then we say it's first degree AV block. First degree AV block is not necessarily associated with any slowing of the heart rate. Okay, you just have a prolongation of the time it takes to conduct the electrical impulse from the atria to the ventricles. The second type of a heart block is second degree, and there are two types of second degree heart block. Let's see. Show you this little video that the medical students did.
Diagnosis when get back.
What?
It's AV nodal block and that's a fact.
Yeah.
Take PI interval and lengthen that.
Yeah.
Brady arrhythmia and heart attack.
Oh no.
Take it to the node. Opioid. My PI interval and elongate. The QRS gets missed, oh what a shame. I think the AV blocking me's to blame. Take some more recordings. Check lead 2. AV type 1 moment. What you gonna do? AV type 1 moment. Hurt me please. AV type 1 moment. I'm blocking all threes. Show me what you're treating with. AV type 1 moment. The sinus. AV type 1 moment. I don't really wanna die. AV type 1 moment. Keep me alive. AV type 1 moment. Get this no going. AV type 1 moment.
Get this no going.
AV type 1 moment.
Get this no going. Get this no going.
AV type 1 moment.
Get this no going.
AV type 1 moment.
Get this no going.
AV type 1 moment.
Get this no going.
Type 1 moment.
Get this no going.
Diagnosis when get back.
Yeah.
Ever since we started on this cardiac,
Yeah.
I've turned into a hypochondriac.
Yeah.
I'm all filled up with those sclerotic plaques.
Oh no.
Take it to the node. Moments one. You see those extra P waves are no fun. I need some atropine or else I'm done. You say benign, oh no, but you're just dumb. Take some more recordings. Check lead 2. AV type 1 moment. What you gonna do? AV type 1 moment. Hurt me please. AV type 1 moment. I'm blocking all threes. Show me what you're treating with. AV type 1 moment. The sinus. AV type 1 moment. I don't really wanna die. AV type 1 moment. Keep me alive. AV type 1 moment. Get this no going. AV type 1 moment.
Get this no going.
AV type 1 moment.
Get this no going.
AV type 1 moment.
Get this no going.
AV type 1 moment.
Get this no going.
AV type 1 moment.
Get this no going.
AV type 1 moment.
Get this no going.
Type 1 moment.
Get this no going.
You ready? You ready? You ready?
Guess I got Winky back.
That's correct.
Them other rhythms don't know how to act.
Uh-huh.
Got those group beats, you know, and that's a fact.
Yep.
Slowing conduction down the AV tract.
That's right.
Take some more recordings. Check lead 2. AV type 1 moment. What you gonna do? AV type 1 moment. Don't hurt me please. AV type 1 moment. I'm blocking all threes. AV
Show me
type 1
what you're
moment.
treating with.
AV
This
type
is
1
going
moment.
with the sinus.
AV
I
type 1
don't really
moment.
wanna die.
AV type 1
Just
moment.
keep me alive.
AV type 1 moment.
Get this no going.
AV type 1 moment.
Get this no going.
AV type 1 moment.
Get this no
AV
going.
type 1 moment.
Get this no going.
AV type 1 moment.
Get this no going.
AV type 1 moment.
Get this no going.
AV type 1 moment.
Get this no going.
Type 1 moment.
Get this no going.
You ready?
So, If we should allow something like that for like a grad project or something, it'd be more fun than Okay, so they were talking about Wenckebach. Wenckebach is Mobitz type 1 second degree AV block. There is also a Mobitz type 2 second degree block, but Wenckebach is Mobitz type 1. That's depicted in figure 118 on page 17. In the second panel, we see it says Mobitz 1 second degree AV block. What do you need to remember about Wenckebach? Well, in some of the EKG books, they talk about recognizing it by the footprints of the Wenckebach. I never found that particularly helpful. But what you will notice is if you look at the P waves, and you look at the P waves and the relationship to the QRS complex, what happens is that with each successive beat, okay, you will get prolongation of the PR interval, again prolongation until at one point you get a P wave not followed by a QRS. You get dropping of the QRS complex. You get non-conduction, okay? You get QRS is dropped. And then the thing starts all over again. The pattern starts all over again. Short PR interval that gradually gets longer, dropped QRS, and then it starts all over again. So the PR interval gradually prolongs until the QRS complex is dropped, and then everything resets itself, okay? So you will see, when they talk about the footprints of the Wenckebach, what you'll see is grouped beats. I think they referenced that in the video. They referenced grouped beats. Unfortunately, the strip that you have here is really short, but if it was longer, what you would take note of is the fact that there are three P waves for every 2 QRS complexes. Okay, that's what they mean by 3 to 2 conduction. There's 3 P waves for every 2 RS complexes. Okay, you might have 4 P waves for every 3 QRS complexes, and that would be 4 to 3 conduction. Everybody see that? So the degree of the conduction depends on how many P waves there are and how many QRS complexes there are. That's Wenckebach. And Wenckebach is usually a benign finding. Okay, usually it's associated with a disease or some process that's affecting the upper part of the node, and it's usually something that's temporary and goes away, as a general rule. Then you have Mobitz type 2 second degree AV block. Okay, and with this second degree heart block, which is not a benign finding, it's not as benign, what you'll see is that you'll see dropping of QRS complexes that is not preceded by prolongation of the PR interval. So the PR interval is constant, and then all of a sudden you'll just see a dropped QRS. All right. Again, that is usually, yeah. Go ahead.
In the Mobitz type 2, I know the PR intervals are constant, but might they also be elongated?
You mean, could somebody have a type 1 and a type 2?
Well, I know that they're going to be the same throughout the PR intervals.
Right.
Well, could they also be elongated constantly?
Yeah, like could you have a PR interval of, let's say, 0.24?
Yes.
I don't see why not, yeah.
Okay.
Yeah. So that, and again, Mobitz type 2 second degree AV block generally implicates disease below the AV node. It's infranodal disease. It is usually not as benign a finding, and those people might need a pacemaker. Okay, patients with Wenckebach, usually not. If it's Mobitz type 2, it needs to be taken more seriously, and you'll talk about that in EKG and clinical medicine. The third type of heart block is third degree heart block, which is often referred to as complete heart block. Okay, and it's characterized by complete AV dissociation. Complete dissociation of the atria and the ventricles. So the atria are doing their things, the P waves are doing their things, and the QRS complexes are doing their things, and what they're doing has no effect on each other. Okay? They are not communicating with each other. So this is a strip that shows complete heart block. Okay? And let's notice a couple of things about it. First of all, if you count the ventricular beats, okay, you'll see that it's very slow. 300, 150, 175, 60, 50. It's going to be less than 50. The heart rate is going to be in the 40s. We said that ventricular. This is probably an accelerated ventricular rhythm, because usually it would normally be in the 30s, but this is a very slow heart rate, okay? Very slow ventricular rate, so it's going to be in the 40s, okay? So that's, we said that you can have that from blocks, but it's got to be, it's got to be either a block in the sinus node or the AV node or what have you. You don't just get it from a bundle branch block. So that's one thing. The second thing that you notice is that the QRS complexes are wide and bizarre. Although it's hard to count the boxes here because the lines are so light, you can see that it's wider than 0.3. The QRS complex is more than 0.3. So you see a wide bizarre QRS, you see a slow ventricular rate, and if you had a pair of calipers, okay, and if the strip was longer, you'd see that this interval is constant, okay? The other thing that you'll notice is that here's the P wave, right? So the question is that conducted to that? Is this P wave producing that? Okay? Well, let's see now. Here you have another, oh wait, there's a P wave, right? There's a P wave, there's a P wave, there's a P wave, there's a P wave. And so what you see is that there's no relationship between the P waves and the QRS complexes, okay? And if you had a pair of calipers and you did this, you'd see that this PP interval is constant, all right? So you have, this is what they mean by complete AV dissociation. The P waves are marching through that strip unaffected by the QRS complexes, and the QRS complexes are marching through that strip unaffected by the P waves. Everybody see that? Any questions about anything we talked about so far in terms of any of the bradyarrhythmias or the heart blocks? Or, yeah.
On this third degree block, isn't that a P wave that is almost inverted, or?
Well, show me what you mean here. You can point to it with this.
QRS system.
Point with the white button there. That's it. Yeah, it's a T wave.
That is inverted. The line where it should go up.
Right. That's part of the bizarre nature of the ventricular beat. Okay. Yeah.
Is there a reason why it's called a PR interval and not a
PQ.
Q?
Well, not everybody. There's not always a Q wave there, so there is always an R wave there. There's always an R wave there, so maybe that's why. I don't know. Other questions? Okay. All right. Let's turn our attention to the tachyarrhythmias. And tachyarrhythmias are going to refer to, again, arrhythmias that are associated with high heart rates. Again, a normal sinus rhythm is going to be between 60 and 100, so sinus tachycardia is going to refer to a sinus rhythm in excess of 100 beats per minute, just as we saw that you could have a physiologic cause of sinus bradycardia in a highly trained athlete with lots of parasympathetic tone. You can also have physiologic causes of sinus tachycardia. So, for example, fever is associated with sinus tachycardia. Exercise is associated with sinus tachycardia. You can have pathological conditions that are associated with sinus tachycardia. So, for example, somebody that has hyperthyroidism, okay, is going to, because of the effect of T4 cardiac tissue. It's going to cause, it's going to give you a sympathetic type of picture, and you're going to have a sinus tachycardia. And you remember when we talked about heart failure, tachycardia is sort of a compensatory mechanism of the heart as it tries to keep up the cardiac output, right? Because cardiac output is equal to heart rate times stroke volume. So if stroke volume is compromised, the heart will try and compensate by beating faster, okay? Okay, let's talk about, and again, there's the tachyarrhythmias can be divided into the supraventricular tachyarrhythmias and then the ventricular tachyarrhythmias. So let's talk about the supraventricular tachyarrhythmias first. And they are depicted in figure 119 on page 18. So let's start, let's see. I guess we'll go in the direction that they discuss them in the book. The first one that they discuss in the text is multifocal atrial tachycardia. Multifocal atrial tachycardia is interesting for a number of reasons. First of all, it is one of the causes of what's referred to as chaos. So if you see a rhythm where, if you have an arrhythmia, there's a couple of different possibilities. Remember, we said you can have a tachyarrhythmia, you can have a bradyarrhythmia, you can have an arrhythmia that's an arrhythmia just because of its irregularity, okay? So there are different types of irregular rhythms, okay? You can have a regularly irregular rhythm, or you can have an irregularly irregular rhythm. A regularly irregular rhythm is a rhythm that is predictably irregular. So for example, when we talked about Wenckebach, remember we said 3-2 conduction, or even the type 2 second degree AV block, we said 3-2 conduction. That's an irregular rhythm, right? It's kind of, it's grouped beats. Boom, 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 stop. Boom, 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 stop. It's irregular, but it's regularly irregular. You can predict what's going to happen next, right? But with an irregularly irregular rhythm, it's just chaos. You cannot predict what's going to happen next based on what's happened before, because the beats are coming at all random times, okay? So examples of that are multifocal atrial tachycardia, which is a cause of chaos, okay? And atrial fibrillation. Atrial fibrillation is also a cause of that. So multifocal atrial tachycardia sometimes has to be distinguished from atrial fibrillation. What is it about multifocal atrial tachycardia that will will allow you to recognize it? A couple of things. First of all, is fast, hence the tachycardia. Secondly, they have 3 or more P-wave morphologies. This is the P-wave, okay? And the P-wave looks a certain way, okay? If you had 3 different looking P waves on the same EKG. So let's say maybe one of them was more peaked, and one of them maybe was inverted, and one of them looked like that, okay? If you had at least 3 different looking P wave morphologies on the same EKG, and it looked like chaos, then you would suspect multifocal atrial tachycardia. Other things to remember about multifocal atrial tachycardia, in contrast to most of the other arrhythmias that we're going to talk about, it is not the result of what's called reentry, and we're going to talk about reentry in a second. It's the result of increased automaticity, for lack of a better term. And multifocal atrial tachycardia, what's happening in multifocal atrial tachycardia, if you look at figure 119, is you have multiple foci in the atria that are firing at different times, okay, and capturing the heart, okay? And so what's happening, that's why you have a different looking P wave. The P wave is changing morphology because one P wave is coming from high in the left atrium, one is coming from low in the right atrium, one is coming from high in the right atrium, one is coming from low in the left atrium. They're coming from all over the place. And so it's going. The shape that they take is going to depend on the path that they take to get to the ventricles. Did you question?
Yeah. For it to be called tachycardia, does it have to have rapid ventricular response?
Yeah, they have to have, they should be more than 100 usually. Okay, if it's less than, if you have the same phenomenon, but the rate is less than 100, then it's referred to as wandering atrial pacemaker. Wandering atrial pacemaker. So wandering atrial pacemaker is basically multifocal atrial tachycardia without the tachycardia. Multifocal atrial tachycardia, and did you have pulmonary yet? Did you talk about multifocal atrial tachycardia in pulmonary? Because usually multifocal atrial tachycardia is seen in people that have pulmonary disease. So COPD would be a common thing. Right. I should have but I don't think I have a strip here of MAT. I'll have to find something for you guys. I don't have one. Okay. The next rhythms that they talk about, arrhythmias, are atrial flutter and atrial fibrillation. They point out that both of these involve reentry circuits, and so this is a good time to talk about reentry. And that's these are the three different mechanisms of arrhythmias. You can have increased automaticity, okay, where a focus that normally beats at a slower rate becomes more automatic because of maybe ischemia or some irritating focus. So increased automaticity is one. That's what you see with multifocal atrial tachycardia. Let's skip this one. This is kind of complicated, so let's hold off on this one for now. The other possibility is reentry. Okay, and this is what's usually responsible for tachyarrhythmias. So what's happening in reentry is that you have an electrical impulse that is descending, and it gets to a fork in the myocardium, basically. It gets to a fork in the myocardium, and there are two different ways that it can go. Okay, there are two paths it can follow. One of the paths is associated with slow conduction. The other one is associated with fast conduction. Okay, so this arm is going to conduct electrically faster than this one will. Okay. The other thing you have to keep in mind is that the arm that is associated with fast conduction has a longer refractory period. A longer refractory period. So what happens is that the impulse comes down. It takes both roads, okay, because it can, okay, and by the time it gets down, this is the normal situation, okay. It comes down the fast pathway. The slow pathway is still refractory, okay, so it can't go back up there. But it comes down here in B. Let's see what we're doing here. It comes down. If it travels down one of the pathways and it gets to the other side, and the other arm of the fork, if you will, is no longer refractory, then what you do is you set up a circus movement. Okay? When the premature beat reaches the circuit, lock can occur in the fast pathway, and the impulse will travel down the slow pathway. After traveling through the slow pathway, the impulse can enter the fast pathway in retrograde fashion, and then enter the slow pathway to start a continuous loop of activation or reentrant circuit. So again, this has the longer refractory period. Okay, this has the shorter refractory period. If a fortuitously timed beat arrives at this junction at just the right time, what can happen is that it can go around the pathway, and it can find one of the arms, which is normally refractory. Okay, it can find it no longer refractory, and so what happens is that it then just sets up a continuous circus movement, and so it's just spitting out impulses, activating. Let's say this is in the AV junction. It's going to continuously activate the ventricles. Okay. Fast pathway has the longer refractory period. down, all right, so it's coming down here. It can't go that way because this has the shorter refractory period, so this is refractory. If it comes down, here it's blocked, but here it's not, okay? It all depends on timing, and it depends on the existence of a slow pathway and a fast pathway. Let's talk about this. We're going to revisit this when we talk about AV nodal reentry tachycardias, but I just wanted to give you a brief introduction to the reentry as it relates to atrial flutter and atrial fibrillation. So if you look at atrial flutter, which is depicted on page 18, figure 119 at the very top, what you see is that the pathophysiology involves what's referred to as a macro reentry circuit in the atria. So it's a large reentry circuit. So this thing is taking place not on a microscopic scale, but on a large scale. Okay. Atrial flutter is recognized by its peculiar EKG appearance. It has this sawtooth appearance, with the atria beating at between 200 and 400 beats a minute, as reflected by those saw teeth, which are flutter waves. They're referred to as flutter waves. Atrial flutter is not a completely, it's an unstable rhythm. Okay, usually it's going to either revert to normal sinus rhythm, or the patient is going to go into atrial fibrillation, which is a more stable rhythm. So atrial flutter is an unstable rhythm. It usually goes in one direction or another. It's relatively easy to shock somebody out of a flutter. I think you use about 50 joules or something to shock somebody out of a flutter. AFib, much harder to shock them out of AFib because it's a much more stable rhythm. And it's not a completely benign rhythm because there is a thromboembolic risk associated with it, although the risk is less than, only about a third of atrial fibrillation. So atrial fibrillation is associated with obviously the possibility of thromboembolism. Atrial flutter is 2, but the risk is only about 1/3 as great. Also, atrial flutter is generally the rhythm is not chaotic. Okay, you'll see that depending on the degree of AV block, the heart rate, the ventricular rate, is going to be variable. Okay, so if the flutter waves are appearing at a rate of 200 to 400 per minute, AV node can't conduct that fast, so there's going to be block. So let's say that you see a rate of 300. Let's just put it right in the middle. Okay. Now let's say the ventricular rate. So the flutter rate is 300. The ventricular rate, let's say, is 150. What's the degree of AV block? Flutter waves is 300 per minute. The ventricular rate is 150 per minute. So what's the degree of block? 2 to 1. It's 2 to 1 AV block. Okay. If it's 100, if the ventricular rate is 100, it's 3 to 1 AV block. Okay. If it's 75, it's 4 to 1 AV block. Okay. Atrial fibrillation, which is depicted in figure 119 on the left-hand side, you see, is characterized by not by flutter waves, but by tiny F waves or fibrillatory waves. And the underlying pathophysiology again involves reentry. You see, it involves multiple tiny wavelets of atrial reentrant activity. As I said before, when we talked about multifocal atrial tachycardia, atrial fibrillation is an irregular rhythm. And we've talked about it before, some of the things that can cause atrial fibrillation, including valvular disease, including mitral stenosis, mitral regurgitation, pulmonary embolism always has to be excluded. Hyperthyroidism has to be excluded in the patient with new onset atrial fibrillation. and some people just get atrial fibrillation. Okay, let's stop here. Let's take a 10-minute break, and then we'll come back and we'll continue talking about AFib and the other tachyarrhythmias.